Hi, I'm Andy Bourgeois, an emergency physician, and I'm going to review how to intubate a patient with known or suspected COVID-19. We want to minimize exposure to staff, so ideally there will only be 3 people in the room: the physician, a respiratory therapist, and a nurse to administer medications. Intubation should occur in a negative pressure room. First, we need to make sure our equipment is ready. A viral filter is inserted between the bag and mask. Then we need to make sure we have an end-tidal CO2 detector, ballard, ET tube with syringe and stylet in place, ET tube securing device, and video laryngoscope. Video laryngoscopy is preferred over direct laryngoscopy for 2 reasons. The provider is farther from the patient, and the time to ET tube placement is likely faster. Ideally, the patient should be pre-oxygenated and denitrogenated by applying oxygen via high-flow nasal cannula or with CPAP. The nurse can then administer sedation and paralytics. The ET tube should be passed as quickly as possible, and ideally just as the patient becomes apneic, so that we don't have to bag while we're manually trying to maintain a good seal. The ET tube cuff should immediately be inflated. Next, the ballard is attached, followed by the viral filter, end-tidal CO2 detector, and then the bag. The patient can then be bagged until a ventilator is ready and the circuit can be disconnected after the viral filter. The circuit should never be broken before the viral filter, and these 3 joints should be taped to prevent accidental disconnection.